In many ways, we could almost do a whole session on question and answer format because there's some really good questions here. So there's some questions that relate to AS, psoriatic arthritis, and juvenile. So I'll kick it off and start off. So there were several questions about diet. So one had to do with what do we know about gluten-free diet and low-starch diet as far as the control of the disease and the role in the disease. So it's a very common question we get. First off, there's not a lot of good research done on the effect of diet in arthritis in general and ankylosing spondylitis in particular. There's some theoretical reasons to think that the bacteria that are normally resident in the gastrointestinal tract might play some role in the initiation of the disease, but it's not proven. We have many anecdotal experiences in our clinic of patients that try different diets. They will go onto a gluten-free diet, a lactose-free diet, low-starch diet, and sometimes a very radical low-carbohydrate diet. The ones that we hear about most are the successes, right? we never really hear about the failures. So I can relate anecdotally that some of our patients find that when they go onto a low-starch diet, they feel better. No, they often lose weight with that, right? So it's hard to tease out, is that a weight reduction issue or is it something specifically about that diet? Our approach has been to make sure if you're trying a diet, and you get different advice from the websites, for example. So there's one of the websites has got a very, kickas.org is very, the low-starch diet is very popular. You know, I'm sure you've seen it on the chat rooms. We feel that the best approach to that is if you're trying an alternative diet, just make sure it's a well-balanced diet, that you're not slipping in any situation of malnourishment or lack of vitamins. And that's usually best, you can discuss it with the rheumatologist or the family physician. I think that we do need some meaningful research in diet. There's not been a significant nutrition trial in spondylitis, and we'd actually like to address that. So the short answer is there's a lot of personal experience about the relationship of diet to AS symptoms, but there's not, at the moment, a lot of good scientific research behind it. I'll just ask, there were 2 or 3 questions related to hormones, so before I pass this down. And this has to do with the fact that women, is there a difference between men and women with ankylosing spondylitis? So one of the issues is delay in diagnosis. So unfortunately, the women with AS have a longer duration of symptoms before the diagnosis is made. That's largely awareness in many ways, and I think Judy's comments this morning really crystallized that. A lot of primary care physicians don't, a young woman with back pain, AS is thought to be a male disease, which is actually not, only partially true. And so that the GPs doesn't really think about AS first when he sees a young woman. Secondly, if you follow patients with the X-ray changes of the spine, so radiographic changes tend to be a little more mild in women than men. Now, another related question has to do with the role of hormones and pregnancy. So we completed a study last year, and the observation that both Vaughn made as well is that pregnancy improves many forms of arthritis, and that's true for most women with spondylitis. So in our study, we found that in the first trimester of pregnancy, the women with AS, their back pain actually improved for the first trimester, and then in the 3rd trimester it got worse, but it gets worse in the control population too. I think the positive conclusion from our study was that when we assessed the women 6 months postpartum and compared with their pre-pregnancy state, there was no significant difference. So in our young women who are contemplating pregnancy, we feel that we now have data to say that there's nothing to suggest that pregnancy is going to worsen or accelerate the course of your AS. The role of hormones are actually not resolved at the moment. We are now doing a study that includes both Canadian and American women with Canadian and American AS patients, women, that have asking about the role of birth control pills. So there's actually very little research on the impact of oral contraceptives on ankylosing spondylitis, and so we should have some answers on that in the next few months when our questionnaires are being completed.
I'll quickly go through what I have here, and some of the questions are for all of us, and so I think we can answer that. The first one that I chose was, it's about long-term therapy. So the question goes, I'm taking the following medicines for almost 4 years, sulfasalazine, methotrexate, folic acid, and it's almost completely healed. Do I have to continue these medications forever? So that's an important question, and we don't have an answer for that, because the trials that have been conducted are, you go on the drug, you get a response, and then you stay on it. There's not been any trial that says, okay, now that you're fine, let's try withdrawing it compared to staying on it and see what the differences are. In other diseases like rheumatoid, we know that once you're on the drug, it's best to stay on it and not stop it, because you tend to flare up once you stop it. On general principles, if you're doing really well and you're healed and there's no toxicity, it's best to continue that. We sometimes do tapers the dose a little bit, but coming off completely, especially if you have had damage, I don't think would be a good idea, because since it's a chronic disease that's now been suppressed with medications, when you stop it, it generally tends to come back. So if there's no side effects and you're otherwise doing well, I don't think you need to, it's better to continue with long term rather than stop it and then have a flare and then try to get it under control again, because in general principles, once you stop a drug and have a flare and restart the drug, there might be a chance that the response is not as great as what it was before, because as you have, when you have more inflammation, you tend to have damage to your joints. Then to Rob and me, the question was, what are new treatments coming up? Why are biologics so expensive? So, new treatments, there are a lot of them coming up. Yesterday we had a meeting, and they said for rheumatology as a whole, there were 260 new 260 new treatments coming up in the pipeline. Some of them will not reach clinical practice, but definitely for patients who have failed a biologic at this moment in spondyloarthritis, we don't have many options left. But with the newer treatments that are coming, we are hoping that that these drugs also would be effective in treatment of AS, and we're looking forward to those newer drugs, but there are targets against IL-17 and many more, not just the anti-TNFs. Why are biologics expensive? We don't make them, but the technology that makes them is pretty difficult to do, and so and then the costs associated with coming to the pipeline and then doing the trial and then recouping that costs are important factors, and they are expensive to make, I think, is the bottom line. And so I don't know if it's the bigger question now is cost effectiveness. Even though it's expensive, is it cost effective, and is the society willing to pay for that? And so cost is a very difficult question to answer, and we're hoping that as years go by, the price will come down, and it'll be easier for access for everyone who needs it. And on the same lines, there's asking why, say, a company like Abbott, why are they paying for research? What are they looking for? Risks of the drugs, or what else? There are a lot of unanswered questions. So once a drug comes to the market, we have to work with the industry partners to understand the drug better, look at long-term efficacy. And the companies like Abbott support research into their drugs, long-term efficacy and side effects and whatnot, and also help in research not directly related to their products. Early diagnosis, use of ultrasound in diagnosing disease early, or looking at genetic factors of disease, which it's in their mandate to do that, as they're also part of the companies that support research across Canada. And so we are happy to partner with them to understand the disease better. And I guess that's my answer for that, but I don't know if I'm giving the right answer there. Again, similar question, what new biologics for PsA? Just like in AS, there's been drugs targeting molecules like IL-12, IL-23, IL-17, which are coming down the pipeline. The clinical trials are being done as we speak, and hopefully in the next 3-4 years, we'll have more options in patients who fail anti-TNF agents. There are questions on why ODSP does not cover drugs early, only after there is damage. We have in the Ontario Rheumatology Association, we have a dialogue with the Ministry of Health to tweak the criteria that they have. And I guess the important thing is cost. The ministry tries to put criteria so that they can restrict access, because the cost of these treatments are pretty high, and we don't have enough funds to treat all those everybody who needs it, I guess. But that's an ongoing dialogue, and when we think that some of the criteria are not appropriate, we go back to them and ask them to change the criteria. Then the ministry takes a decision based on other factors. And it's not always been very transparent in how they come to that decision. And we also agree that in patients with, if we can identify patients who are likely to get more severe disease, they should be treated early and aggressively. But at the moment, apart from clinical features and X-rays that can predict severity, we don't have many more markers. And some of the research that we're doing is to identify markers, blood markers, genetic markers that can predict patients who are not going to do well and so need more aggressive therapy. Questions about MRI. Are there locations in Ontario where we can do open MRIs, meaning avoiding the claustrophobia? For the spine, I don't think we can do that. But for peripheral joints, hands and feet, there are office MRIs which are as good enough. So you can stick your hand in and get that MRI done. It's available at the Mount Sinai Hospital. But for the spine, we need to go into the tube to get an MRI done. And a lot of patients can't get the MRI done because of weight issues and claustrophobia. It's a question about whether the disease affect the jaw joints. I think you're meaning the temporomandibular joint right in front of the ear. It's one of the joints that are affected in these diseases, especially in kids. And it can be debilitating, can prevent you from chewing, opening your mouth, and management is, if it's severe, treating the whole disease that takes care of the inflammation would help your joint, the pain and swelling in your TMJ joints as well. If it's just one joint and it's swollen, you can also inject that joint, and that can help. But it's not just the joint, you manage the whole disease appropriately. The last question that I have here is there any evidence of kidney stone increase in patients with biologics? No, I don't think so. But kidney stones, especially in psoriatic arthritis, there's a higher prevalence, I guess. There's no study that compared the two, but kidney stones are many times associated with what we call metabolic syndrome. And since there's a higher prevalence of metabolic syndrome in patients with psoriasis and psoriatic arthritis, you tend to have kidney stones associated with this problem because the uric acid levels are high, but not particularly related to treatment, but maybe related to the disease per se.
So I have some questions really related to, I guess, family planning. So certainly patients with AS who are thinking about having kids, and also those with AS who have kids, is in terms of, is there any risks for the kids, what they can do, is there any special screening? So the key thing to remember is that even though you have AS, most times, with your children, they will not have AS, okay? So if we look at overall, as we mentioned before, people who are B27 positive, okay, less than 1% of people will actually go on to develop ankylosing spondylitis. So to have the B27 alone is not enough, to say absolutely you're going to go on to get disease. If we look at our highest risk factor, where you as a parent have AS and you're B27 positive, and ultimately, if you do screen your children, which is not what I'm telling you to do, but even if you do and you find your child is B27 positive, less than 10%, okay, of those kids will go on to develop any spondyloarthritis, okay? That means, 90% of the time, your kids are going to be fine and they're going to be healthy and live, very healthy and productive lives. The key thing is, and I would advocate you don't need to screen your kids with the B27, okay? I think the more important thing is to pay attention, to some of the symptoms. So for the very young, for me, okay, young meaning those that are kind of like maybe 8 or 9 or younger, okay, remember in that population, the most common thing is going to be inflammation of the joints, okay, or the entheses. So I'm not just talking about aches or pains now and there, is that you're seeing or your child is either complaining or that you see, repeatedly every day for several weeks that they've got either a sore or swollen or warm joint, or first thing in the morning, they're slow to kind of move or having some of that stiffness. Those are times that we may need to look further, okay? I would say in the older for me means those that are in their teenage or tween years, if there's not another reason where they're having, again, symptoms of not just back pain, but what we learned today, very specifically symptoms of inflammatory back pain, repeatedly every day, then those are kids, I would say, that probably just need to have a good assessment by either their primary care physicians, family doctor, pediatrician, and if worried because of family history, if they want to have a good, good assessment by a rheumatologist or pediatric rheumatologist, then that would be the time that you can actually advocate on your child's behalf that I'd like to see an arthritis expert. Because I would say sometimes, sometimes it's hard that if you don't, look at very subtle joint inflammation in the beginning, they may miss that. And that's the time that you may want, just because of some concerns or a family history, then you can get referred to a pediatric rheumatologist, and we're happy, and I've done that before, that in some, high-risk families where multiple members are there, and sometimes I will just screen a child or just see them, once a year or once every 2 years, just to look at all the joints, just to make sure everything is fine. The other question was really family planning again. So do any medications, so specifically anti-inflammatories or biologic, affect fertility or the ability to conceive? So I would say that the main thing is really, if you're thinking about family planning or you're good enough to think ahead of time, is to speak with your rheumatologist, because then they can look at what medications you're on, and potentially if they need to make any changes to kind of make your chances of having a child or having a healthy child, they can discuss that. And I think it has to be quite personalized. There are certain medications that we'd like people not to be on when they're pregnant. So for example, methotrexate, okay, is something. So it's not to say it doesn't affect your ability to have children, but we don't want you getting pregnant because it's one of the pathways that you need for a growing baby inside of you. So oftentimes if you can think ahead, you can discuss with your doctor and they can find an alternative or safer one for you to be on. There's also questions about biologic safety. Are there any particular ones that are the safest with less reaction? In particular, somebody asked about neurologic problems. So again, I think there's no perfect medication without a side effect. And the other thing is it's hard to make generalizations because each and every one of you, I think, need to be treated as an individual. And we can't predict. Some of you may be more sensitive, others may be more tolerant to certain ones. And I think that's an important thing, just discuss with your rheumatologist about the most common side effects. And sometimes it may be a bit of a trial or error to kind of see, if you're able to tolerate, but to communicate. If you're really not tolerating something, don't wait. like, please let your rheumatologist or their team know earlier on, because sometimes it may be as simply as adjusting the dose that can make it more tolerable, or if really you don't tolerate, there are other options. In terms of neurologic problems and biologics, so biologics itself do not cause neurologic problems, but what we've learned with some people with particular neurologic problems, so for example, people with multiple sclerosis where the insulation around the brain gets affected and kind of breaks down, we have learned that people who get put onto an anti-TNF agent, their condition can worsen. So that's something that before people start a biologic, those are questions that your rheumatologist will probably ask you about. And I think the major ones in particular are, if you yourself have multiple sclerosis or family history, or the other thing is heart failure, those are two things that we want to make sure that you don't have before we can say, because in those cases it can worsen. The other thing, it's part of the screening that we will, it's not to say you can't have it, but we take special precaution, is a lung infection called tuberculosis. So oftentimes, many of you, before your biologic, you know that you will be screened for that to make sure that you're safe and you don't have that. The last question I have is really talking about the immune system. So if you suppress it, are there bigger risks, and basically in particular, they'd say from colds to cancer. So remember that if we talk about inflammation, so whether it be in the joints or the spine or in your entheses, right now your immune system, what we're calling, is working too much in the wrong way. So just think of it like I would say like a little seesaw balance. So most of all the medications, what we're doing, we're not here to shut off your immune system. The target, what we're trying to do, is actually to bring it back into balance, okay? So it's not working too much in the wrong way. And so I would say that if most of the medications weren't shutting things off completely, we're not really eliminating your ability to help fight against these infections. Because the medications do dampen that, okay, sometimes your ability to fight certain infections may be in that sense a little bit weakened. And so, the main thing is, we would say is, should you have a high-risk infection, high fever or something, we're not saying you have to run to the emergency ward, but we're just saying those are things that, before when we're told, okay, just wait, rest, take some Tylenol, drink some chicken soup, we're just saying to a lot of our kids, if you have a really high fever, it may be something that you may want to just see your family doctor sooner, for the sake that, if there's any infection that requires treatment, i.e. with an antibiotic, we kind of like that on sooner rather than later. And obviously if it's a, serious enough infection that you either need an antibiotic or hospitalized, and those are times that we may at that point in time like hold or adjust your immunosuppressive therapy until you're over that. But if it turns out it's just a cold or flu, most people are safely able to continue on those immunosuppressive therapies. Now the big question is really, cancer risks, okay? So there's a couple of things to think about, is that, do immunosuppressive at any level, do they cause cancer? So I think in terms of, if we look at the data, what's out there, we know that underlying untreated inflammation puts you at higher risks for cancers. We also know, depending on your makeup, you actually have your own risks or susceptibilities to certain cancers. Now the theory is that, where medications come in. So you have to think of it, as I tell my families, your immune system has good things that it does too. Fights, the first thing is fighting against infection. But your immune system, also think of it, is one of the roles is kind of like a vacuum cleaner. That if your body in itself sometimes may kind of make some cells that are not perfect, okay, that your immune system's, one of its jobs, like a vacuum cleaner, is actually to get rid of those cells early on. And the whole theory about cancer cells is that it's rapidly dividing cells that are not formed properly. It's out of control. That's what forms, cancers. So the question is if you do kind of, I guess, turn down your immune system sometimes, and maybe the ability of those vacuum cleaners as your first line of defense against any, abnormal cells is do some of those cells pass through? And if you had like an otherwise risk for having a cancer, does that affect that? So you know, we usually say there's a theoretical risk just because of that role, but if we look at the data of you know, people who have been on biologics versus those who are not with the same disease, we haven't seen any increased signals that the ones that are on biologics with the same disease and everything, you know, have much higher cancer risk than other people with that. That's something we look for, and that's why while you're on, you know, any medications, immunosuppressor biologics, that's where when you come for your routine follow-up, we're very careful. That's why we're always doing a checkup for other things outside your joints, blood counts, looking for any earlier signs of that.
Okay, I'll run through a number of questions on different themes in no particular order. What about false negative tests? My sister has a lot of classic AS symptoms, but her B27 is negative and she's still symptomatic. So remember, 10 or 15% of AS patients are B27 negative. We think that it's slightly milder disease, possibly in terms of X-ray changes, but real bona fide AS does occur in the absence of HLA-B27. So particularly with a family member who's very symptomatic, it's very important that that individual will get a good rheumatology assessment. And that usually would mean a history and physical. And so despite the fact that B27 is negative, appropriate lab tests, X-rays, and possibly an MRI. If the symptoms are still persisting and they're not resolved, then it's very important that the clinician not be dissuaded by a B27 negative test. Is it, another question related to B27 negative, why aren't we using it more? It's not a particular, it's about a $100 test, and it's relatively painful. Why don't we use it more? It's a very good question. As we talk to our GPs, our primary care physicians, the question is, should they be using the B27 test more frequently in the assessment of back pain? It's an important question that actually still hasn't got a simple answer. And the problem is that if you take 100 patients with chronic back pain, probably only about 5 or 6% will have ankylosing spondylitis. About 90, over 90 of those 100 will have what we call mechanical or disc-related back pain or degenerative disc disease. And so that's much more common in the population. The gene occurs in 6 or 7% of healthy individuals. So there'll be a certain percentage of people who are B27 positive, who've got chronic back pain, and yet they've got a mechanical source of their back pain. It's not spondylitis. So that's, in a nutshell, why we try to use that test in a targeted population. Because for a busy GP, if it's routinely used in a primary screening back pain cohort, then there are a lot of false positives. But it's a very important question. One of the issues that the Spondylitis SPARC, the Spondylitis Research Consortium of Canada, we've just actually submitted a grant to Genome Canada to actually develop a better genetic test at the primary care screen level. So at the moment, if you just use B27, there are too many false positives. But there are 5 or 6 candidate genes now that have come out from our studies that have better specificity. So if you take those 5 or 6 genes, in addition to B27, now we are talking about something that's got good sensitivity and specificity, and it really might help at the front lines. Interestingly, it does not take a blood test, it just takes saliva. So all you need to do is spit, and we'll get your DNA taken care of. So don't spit at your rheumatologist, though. Extra-articular features, iritis. So as I mentioned, there's a concern here about eyes. Is the about 30 to 35% of the AS patients will develop anterior uveitis. That's inflammation in the anterior part of the eye. It's also called iritis at some point in the disease. The good news is it's a very treatable condition. So you should, if you've had it before, you know it. Its symptoms are insensitivity to light, a lot of night pain, but particularly pain in the eye, but also blurring of vision. It's a very important condition because untreated it can lead to glaucoma and cataracts. But once so it's very important that it be diagnosed appropriately and treated quickly. So many of our patients that have had episodes carry their topical steroids, it's called Predport, and at the first sign of eye symptoms, they get the drops in. So it's important. So at any point, an AS patient that has unexplained eye pain or blurring or sensitivity to light should see an ophthalmologist. Despite those potential complications, the good news is it's very treatable. It's very, very unusual to lead to permanent loss of vision in our patients, which is good news. The other important feature is Crohn's, besides the eyes, it's the Crohn's. So can a patient who has had AS for more than 10 years still develop Crohn's disease? Yes, indeed. We actually have a patient in our clinic who's a dentist who's 51 years of age who developed Crohn's disease and ankylosing spondylitis at age 51. That's unusual. As you saw from the chart of onset of the symptoms, it's predominantly in the 20s and 30s, but late onset disease does occur. Whether the Crohn's disease precedes the spondylitis or vice versa is quite mixed. So we have patients in both categories, in which case the patients really are followed jointly by the rheumatologist and the gastroenterologist. Back to causality. What about trauma? So is there a relationship between injuries sustained in a motor vehicle accident and the development of AS? This is a very common question. It's a very important medical legal question. A patient might have been minimally symptomatic, never had any reason to get an x-ray of their back or the neck. They get rear-ended at a red light, and now they got a whiplash injury. And instead of just getting better quickly, the neck pain gets worse. They see their GP, and there's diagnostic changes of ankylosing spondylitis. Now, then you call the lawyer, right? So the problem there is, the question is, what was the role of that injury in the onset of the disease? So our current concept of ankylosing spondylitis is that injury is not a causative role, right? But as far as we know. But there's no question that an injury could change the level of symptoms. So we've had some, not only car accidents, but industrial accidents. We have a patient that fell off, it's a house painter, fell off a ladder, landed on his back, and that just seemed to set the stage for everything. So our thinking at the moment is if you have a genetic predisposition to this disease, B27 and other genes, that an event like an injury, like trauma, could actually change the course of it. It might actually, your response to the inflammation related to the injury might be altered. And then you can leave it up to the lawyers to figure out who's got the better case. So, but it's a very important question in WSIB cases, because if a work-related injury occurs in a B27 positive patient, is that because he was genetically predisposed, or was it the work-related injury that actually played the role? So it's a very important question. There's an entity called enthesitis. So we mentioned that on the slides. You saw it in Dr. Chandran's talk. What about tennis elbow, Achilles tendonitis, all these other tendonitis sites? So it's a very common feature of these forms of disease, both psoriatic arthritis and ankylosing spondylitis. An enthesis is where a tendon inserts into bone. And that can occur any part of the body. So a tennis elbow, Achilles tendonitis, the heel pain, or what we call plantar fasciitis, just about any site in the body where tendons insert into bone can be a target for inflammation. And in some of our patients, it actually can be quite disabling. It can be as disabling as the back pain, because if you can't walk on your feet in the morning and put any weight on your heels, you're in for a tough day. Fortunately, most of the trials with Humira, Enbrel, Remicade, Simponi have actually shown good effectiveness against both the tendonitis or enthesitis aspect as well as the spinal involvement. But it can be we don't really understand what the mechanism that is. It's quite different, for example, than rheumatoid arthritis. In rheumatoid arthritis, heel pain is a very unusual feature, but it's very, very characteristic for our pain. What about a chiropractor? So the question here, I've got AS, will a chiropractor help or hurt? So we try to work closely with the chiropractors. There's a history of sort of a polarization, maybe even antagonism between MDs and DCs. We're trying to work more closely, bring the two communities into discussion. There's evidence, for example, in acute low back pain. So this is the mechanical strain. You go to Pearson, pick up your suitcases wrong, and you're knocked out for the acute low back pain. There's actually some good evidence that chiropractic does as well and maybe better than traditional medical treatment for acute low back pain. When we come to chronic low back pain, it's more complex. Our concern, and this is where I think communication is very important. If the chiropractic approach has been primarily for massage therapy and exercising, we're all for it. If it approaches more manipulation therapy, that's where our concern is. So if a patient has got significant spinal restriction because of bone spurs, we call syndesmophytes, we are extremely cautious to have that patient undergo any kind of spinal manipulation. One of the paradoxes of this disease is even though there's excessive bone formation taking place in the spine, you actually have osteoporosis as well. So you might be predisposed to a fracture in a way that a normal individual would not be. So we try to communicate that concern to our patients and to our chiropractic colleagues. As I mentioned earlier, it's very important. Many of our patients see chiropractors long before they see rheumatologists or even GPs. So one of the challenges for us is to sensitize the chiropractic community to what AS looks like in its early stage. Why is radiotherapy never mentioned in AS? I had radiotherapy for severe AS, nothing else worked. This is radiation therapy, that the cancer doctors use extensively. If you deliver radiation to a point of inflammation, it's a very effective way to treat that inflammation because it actually it eliminates all the inflammatory cells at that site. And in the older literature, that would be in the 50s and 60s, radiation of the sacroiliac joints was used quite extensively and quite commonly. The reason it fell out of favor was concerns about secondary cancer risk. So as you know, radiation itself is a risk for secondary cancers. So in the 80s and 90s, as effective nonsteroidals came on the market, and even more significantly since the year 2001, since the biologics have come on the market, radiation therapy for spondylitis has really, for the time being, gone to the back burner. I've been taking two medications, methotrexate and folic acid, for 4 years, and things are very good. Do I have to take those forever? That's a good question. It's a question actually that applies to the biologics too. One of the differences between remission and cure is that you're still dependent on a drug, right? If you're cured of pneumonia, you can stop your penicillin 2 weeks after the treatment and there's no more pneumonia. When we treat a disease like psoriatic arthritis, rheumatoid arthritis, and spondylitis with these agents like methotrexate or even biologics, we can achieve very effective control, but the experience has largely been if you stop those medications, you might stop them for pregnancy, for illness, for surgery, that the symptoms start to recur after a period, sometimes after a biologic, for example, 3 to 4 months. So we are effectively controlling the disease, but we're not curing the disease. So the short answer is that if your symptoms are well controlled with methotrexate or biologics, and you're interested in a drug holiday, talk it over with your doctor carefully. Because, and there's actually some trials that are looking at this now, whether or not we can actually induce long-term remission. I can't take anti-inflammatories because of ulcer problems. It's a big issue. In fact, one of the tremendous breakthroughs with the biologics was patients that were really in the 80s and 90s totally dependent on Voltaren, Indocin, Advil, and they were doing a lot of damage to their stomachs, could throw those away and get onto an anti-TNF agent. So that's been great. But the patient also says, I also have fibromyalgia and I'm taking analgesics for that. So secondary fibromyalgia. Fibromyalgia is another term for chronic pain syndrome, and it overlaps significantly with chronic fatigue. So a lot of the features may overlap. I mean, fatigue is one of the dominant features of ankylosing spondylitis, and it's the hallmark of fibromyalgia. And indeed, some of these tendinitis sites that occur in ankylosing spondylitis are sites that become tender in fibromyalgia. A little wrinkle in the diagnostic confusion sometimes. It's an important question, and I think an experienced rheumatologist dealing with that on a one-to-one basis is very important. Because we've had patients, for example, whose main features improve significantly with a biologic agent, but they're left with other features that are more consistent with fibromyalgia. Interestingly, fibromyalgia is much more common as a complication of degenerative disc disease than it is of ankylosing spondylitis. It may have to do with the demographics. Remember, most of the AS patients are significantly younger than the fibromyalgia patients. What about chest symptoms? There were two questions about rib pain and coughing. So rib pain is partly a manifestation of the enthesitis we talked about. So one of the most distinctive features of AS, and some people in the room have experienced this, is costochondritis. So this, where your rib inserts into your breastbone, there's a series of joints there. And that's really quite a common site for inflammation and ankylosing spondylitis. So our AS patients, of all the patients, as we heard from Judy, need a hug, and sometimes getting a hug can be very painful. Happily, those symptoms, those other sites generally improve with effective biologic treatment. We generally don't encourage, like steroid injections in those joints are uncommon. So if one of our patients has persisting rib pain or chest wall pain, it hurts to cough, it hurts to take a deep breath, that means we're really not on top of the disease yet. So either we need to move up to another agent or consider switching that agent at that point. Are there surgical options to reverse the fusing of the spine? That's an important question. We have a very active spine service at the Western with some very experienced spinal surgeons. Fortunately, it's a rare event, first off. But there are patients in whom their flexion deformities are such that it really becomes a real problem. So I have a patient who is a realtor, for example. His posture from AS is very deformed, right? He's had it for years. And so when he's communicating with a client, it's very difficult because he actually doesn't to make eye contact. And I actually have a principal of a high school who has to sit back, way back in his chair like this to make eye contact with all his staff. So there are circumstances in which the posture change imposed by the spinal deformity is such that it really is a major impact, particularly on your professional and social life. So there's a procedure called a spinal osteotomy. So what the spinal surgeon does, he takes a wedge of bone out and actually takes the flexion that occurs like that becomes straighter. So that has some utility. You need an informed opinion from the GP and the rheumatologist, and you need a very experienced spinal surgeon. And everybody has to be, I think, in agreement. But in experienced surgical hands, we've had some wonderful results. That's also true for hip replacement, by the way. That slide I think you saw of that young man that was getting progressively deformed over time, it was actually a patient at Sunnybrook many years ago. That last slide, when he seems to be more upright, is because he had hip replacement surgery. So sometimes we find the stoop that our patients are experiencing is not so much from the back, it's from the hips. And if they have hip replacement with an orthopedic surgeon, actually their posture can improve significantly. So surgery is definitely part of the overall plan, but it's a small component. We talked about the safety of biologics, which I think, once again, to reiterate Shirley's point, the long-term side effects profile for the biologics is very encouraging. So we've had Enbrel and Remicade on the market for 10 years. We've had Humira on the market for 9 years, and we've had Symphony on the market for about 4 years. So if you pool all that experience around the world, you have thousands of patient year exposures to these drugs. And again, one of the advantages of the electronic age is that we are the beneficiaries of all these longitudinal cohorts. So for example, the British Society of Rheumatology has a biologics registry. There's a registry in Sweden. There's a registry in Denmark. These are large numbers of patients that are followed sequentially. And so instead of just watching our clinic or even the Ontario or the Canadian population, we can now watch for side effects globally. And the very encouraging aspect about the long-term follow-up is that with longer duration of observation, we have not seen any more serious concerns about unusual infections or unusual cancers. So that's not always the case. You know, some medications come on the market, they look great, and then as patient experience expands, we see more problems than we saw in the early stage. The good news for the biologics is it's actually the opposite. Normal lifespan, there's a good question. Can people with AS live a normal lifespan? So that's actually been shown if you stay away from dangerous medications and dangerous surgery. So the life expectancy for AS is actually not delayed, which is very encouraging overall. Is there an advantage of MRI over CT scan in the diagnosis of AS? So this is a common question we get from GPs because if the X-ray of the pelvis, that's the sacroiliac joints, is not diagnostic, so what's the next best test? There are two reasons why an MRI is preferred over a CT scan. One is there's no radiation exposure, so CT scan imposes significant exposure to radiation. MRI has no radiation exposure. More importantly, MRI is a detection of inflammation. CT is a detection of damage. So if the question is there any damage that has occurred in the sacroiliac joints that might have been missed on the X-ray, CT scan's okay. But the question that's usually being asked is this patient's back pain coming from inflammation? In that case, the MRI is far superior. In fact, the MRI really is the most sensitive test that we have for detection of early inflammation. Okay, I think we've just got about, there's one last one on sarcoidosis, an interesting question. Sarcoidosis is actually it's an unusual sort of autoimmune disease. It's actually proved to be quite responsive to anti-TNF agents. Once in a while, we've seen it as a very rare side effect of anti-TNFs, but it's very, very unusual. I think we've hit them all there. So any other? So, oh yes. So just to conclude, this has been a wonderful day. Thank you very much for coming. I mean, I must tell you that from yeah, this may come as a surprise, but the physicians actually learn as much of these sessions as we do. Hearing like our two speakers today, I'd like to thank Vaughn and Shirley and Judy. They were outstanding, and I find those presentations both moving and inspiring. So thank you to both of you. And I'd particularly like to thank Abbott, the sponsor for this session. The question came up about academic pharmaceutical partnerships. We have got a common goal, and that is to make sure that unrecognized AS patients are diagnosed appropriately and appropriately treated. And we have in that sense, we have a very convergent set of objectives with our partners like Abbott. And so it's great to work in partnership, and I'd like to acknowledge their support today. Thank you. And of course, that's the Arthritis Society's primary mission. Of course, is to unresolve the cause and to define the cure of arthritis. So we've been working with the Arthritis Society. We, the rheumatologists, have worked for many years and will continue to work hand in hand with the Arthritis Society. Make sure we're, as Michael said, representing the CSA, that we value your comments on the day today. We really would like to improve the sessions, but we'll do so if we're meeting your needs and answering your questions. And once again, the CSA is growing fast. I think there's still some memberships available if you want to get in, but we would really encourage you to join. If we speak as a community of physicians and patients, whether it's access to MRI, I might say, again, one of the concerns in the Ontario scene is that availability of MRI for back pain is actually a point under discussion. And we and you, the voters of Ontario, with dealing with arthritis, can make your voices heard. So once again, thanks and have a great day.